For those of us who've been practicing for a few years, we're very familiar with the term non-reconstructible arterial disease. When I was an intern, that meant that someone couldn't have an above-knee fempop bypass, at least in many institutions. It was when I was in training that the concept of tibial artery revascularization became more widely discussed and accepted. And it wasn't until maybe the 1990s that became the standard of care at most institutions. But there were still places, including major centers such as in Houston, where if they couldn't do an above-knee fempop with a prosthetic graft, it was non-reconstructible, and that was amputation. Well, most of what we do for critical limb ischemia involves complex revascularization with bypass to distal targets or atherectomy or angioplasty or stenting at multiple levels. But there's still patients who we don't have the technology to treat with revascularization. And in those cases, we're interested in medical therapies or angiogenesis or other adjuncts, including stem cell or regenerative medicine therapies. We have with us tonight Jan Nolta, who is the director of the stem cell research program at UC Davis, to talk about stem cell therapy for critical limb ischemia. First choice or last ditch. And it may not be that we have the answer quite yet, but we're heading in the right direction. Dr. Nolta.
Thank you so much to my wonderful colleagues at the UC Davis Vascular Center. It's just been great working with all of you since I've been back to Davis for the last 4 years. And I think we're working on some really exciting and innovative things. So tonight I get to very briefly talk about my favorite passion, stem cells. Verbal disclosure, I have no disclosures. All NIH funding and California Institute for Regenerative Medicine funding, so no companies. We have a large program at UC Davis of people working on stem cell therapies. So these are the 15 different disease teams that we have formed, 15 different areas. These are made up of 147 basic translational and clinical investigators working together. And we can only truly get to the best therapies if we do work together. So the basic scientists, we understand the stem cells, we understand what they do in the dish, but we'll never understand the disease. We need to work very closely with our clinical partners to even understand how we're trying to get to the best therapy. So tonight I'll be talking about things that pertain to our peripheral artery and CLI disease, revascularization to prevent amputation, also applicable to our heart disease and infarction repair team. So just very basically to make sure that everybody's on the same page, 2 types of stem cells. Adult stem cells is what I'll be talking about this evening. These are blood-forming hematopoietic stem cells and also the mesenchymal or supporting stem cells that we find in the bone marrow. These make the factors to keep the other types of cells alive in the bone marrow. There are also these things that you read about in the papers, the pluripotent stem cells. The embryonic stem cells are the very controversial guys. This is a colony of about 1,000 of those embryonic stem cells. This is the H9 line, first made 12 years ago and distributed all over the world. Every embryonic stem cell lab uses vials of this same stem cell. We're now able to make a new type of stem cell, induced pluripotent stem cells. We take a little bit of the patient's skin, de-differentiate the cells, and make them into these induced pluripotent stem cells that are very similar but not identical to embryonic stem cells. Excuse me. And I won't talk about these anymore. I'm going to talk about the adult stem cells because that's what we can harvest from the patient and really use therapeutically. So we as a field, not me personally, have had a lot of experience working with adult stem cell therapies. These began in 1956. This was with hematopoietic stem cells used in bone marrow transplantation. Millions of lives have been saved by this therapy. It's completely reimbursable by insurance. That's where we'd like to get with these other stem cell therapies. And this is due to the properties of stem cell homing. So we can take the stem cells out of the bone marrow, put them in intravenously, and they find their way back into the bone marrow. And the first time that I encountered this 20 years ago, I thought this is just incredible. How do those stem cells know to find their way back into the bone marrow niche? They also can find their way to damaged tissue and to hypoxic tissue. And that's the properties of these stem cells that we capitalize upon when we're using them to try to heal injuries. We can track the stem cells. We can have them eat up these little fluorochrome conjugated ferridex nanoparticles overnight. It's like a glowing iron dust. They take them in very readily, actually in a couple of hours. We can then track to see where they go inside the animal. Experimental animal. Combined X-ray and fluorescent imaging station allows for us to see where these cells have gone dynamically. So we can look over each day in a living mouse and see where the stem cells have distributed. We've used this in a model of myocardial infarction. So we have mice with no immune system. We can study the behavior of human stem cells in these mice, and the Food and Drug Administration really likes that, because what they want to see from us when contemplating a stem cell therapy is that we use the stem cells manufactured in the same way that we would use for the patient, and then test them in some manner to make sure that they're safe and effective. So if we do experimental injuries in the immune-deficient mice, we can follow where the human stem cells have gone and see what they've done. So we tie off the coronal artery in the mouse, inject the stem cells, see that they go into the hypoxic region. We just injected them IV in this case. They particularly go into the hypoxic region in the front face of the heart. And we and many others have documented that they are particularly attracted to areas of low oxygen. That's what they like, and that's what activates them to secrete more and more angiogenic factors. And we have published this with my excellent postdoctoral fellow, Klaus Sondergaard. So we can model a peripheral vascular disease in the mice. We actually cut out a segment of the femoral artery, tie off collaterals. By laser Doppler imaging, we get no blood flow down into the foot that we've done the surgery on. We have the contralateral limb as a control. And then we can use those ferridex particles, the imaging. These are controls, it's a microfuge tube with a certain number of the stem cells in the bottom. So we can see where the cells go after we inject the label cells into the tail vein of the mice. We can see that 12 hours after infusion of the cells into the injured mouse, that they go specifically to the damaged leg and not to the contralateral limb. In 48 hours, they've really massively accrued into that area of hypoxic damage. And by the way, this surgery is done up here, the femoral artery, and it's just getting really hypoxic downstream, so that's where they accrue. Looking at laser Doppler imaging over time, we have an interesting population of stem cells from the bone marrow. These are the aldehyde dehydrogenase high stem cells. This is a fancy term for a mixed bag of endothelial, hematopoietic, and mesenchymal, very early stem cells. So we have studied these. We can see that the ALDH high population causes almost complete recovery by day 21. The ALDH low, which is committed progenitors but not stem cells, really doesn't do much compared to the PBS control, which is basically injury alone. And so this ALDH high population promoted almost complete correction by day 21 in this mouse model. And remember, the femoral artery is gone. So what's happening there? The stem cells are actually going into the area of the hypoxia and increasing the diameter in small microvessels that are in the tissue, already in the tissue. So they're not growing that femoral artery back as early as 7 days. We can see a significant increase in 7 days. They're opening up these small little collateral vessels and allowing blood flow to go back into the injured tissue while remodeling begins to take place. So in translation to the clinic, our preclinical data was used by the biopharmaceutical company Aldogen. They initiated a clinical trial for patients with end-stage critical limb ischemia, and those patients had amputation as the only option. That clinical study was successfully completed. The group of treated patients experienced increased blood flow in the affected limb, and 1 year out from the trial, 9 of 10 limbs were retained. Phase 2 trials for PAD are pending with this company. We've been waiting, but that same stem cell product is currently in phase 2 trials for stroke. Now, we work a lot with mesenchymal stem cells. Those are the broad, flat cells that I showed you in the bone marrow that are really nurse cells for the other cell types in the bone marrow. These are the paramedics. We often call them the paramedics because they are very, very good at getting to areas of injury after infusion. They have a strong safety profile, and they are adult cells. They can't create an entire tissue. They're not going to make you a liver or a kidney, but they can help revascularize it. We get these either from bone marrow, from brave donors, from the iliac crest, of course, or from adipose tissue. So this is a gob of ugly fat from gastric bypass surgery patient, sorry. So I started out at UC Davis, but then I went down to Los Angeles for 15 years, and we were getting just liters and liters of lipoaspirate material to grow our stem cells from all of the starlets that were having the liposuction. And then I was recruited to Washington University in St. Louis, and not so much cosmetic surgery going on in the Midwest. So we started getting the actually buckets of fat from the operating room, and we would have to digest it ourselves. But just for a little, levity after dinner, here's what that looks like. So it requires a lot of processing, but we can get the same nice cell population out of it. Now, what's interesting about these cells, I mentioned that they have a strong safety profile. That's actually in human patients. So these are expanded, non-matched allogeneic mesenchymal stem cells. They look like this when we grow them out. It's just a nice monolayer in the flask. They've now been used in exciting human clinical trials to mediate tissue repair. Companies such as Osiris, Athersys, and then many investigator-initiated phase 1 to 3 clinical trials for different diseases, including many revascularization diseases. So over 1,000 patients have been treated in the USA through FDA-approved trials. Early results are promising, and the cells are safe. So this is what these mesenchymal stem cells look like. And you can see how very social they are. So they like to be together, and not only do they like to be together, but they maintain contact with the other cells around them for quite a while. And we've shown that they can directionally infuse factors into the other cells. So not just growth factors that they're making, but actually microRNA and different things that can control the fate of the other cells. They don't exchange nuclei, but they can exchange a lot of cytoplasmic contents with the damaged tissue, and they're continually pumping out loads of growth factors, including a lot of angiogenic growth factors. So we actually have a huge veterinary medicine, regenerative medicine camp out in our veterinary school, and this is the Center for Equine Health. And they have been treating many, many horses with their own expanded mesenchymal stem cells. So this is for athletic injury. They also treat those horses for vascular disease, knee, tendon, and bone repair. We have a lot of team training opportunities. We meet as teams once a month. And they have a laboratory out there to grow out the horse mesenchymal stem cells. And they have a racehorse cord blood bank. We don't have a human cord blood bank at Davis. We're working on it, but there's a racehorse cord blood bank. So the horse owners believe so completely in this therapy that they're willing to pay to bank the cord blood when they have a foal born, because they think that that horse might need it later. And these therapies can be just amazing sometimes. So what's best, allogeneic or autologous mesenchymal stem cells? For animals, we have to use their own. You can't use another animal's. The FDA won't allow it, interestingly. For humans, we can, and that's almost all that see it. Yeah, the paradox, I know. So there are pros and cons. So autologous, we have the possibility of minimal manipulation from the adipose tissue. So there's a company, Vetstem, and they make a product for animals. They just, you send a couple of inches of the animal's fat that your vet's taken out. They send you back a single cell suspension and you inject it. This has been especially effective for osteoarthritis for canines. We have Cytori for humans, kind of doing the same thing, except it's not allowed in the United States. All of the European countries are doing that. Fewer regulatory hurdles, and your own cells maybe retain longer or work better. This really isn't known in humans. The allogeneic cells are very interesting because they can be banked and certified in large batches. They would then be available to thaw and infuse for any patient at the time of injury, say if they come into the emergency room or are in the ICU for a heart attack. Much more regulatory issues than autologous. You have to really certify the cells when you're banking them and show that they're free of all viruses and adventitious agents. And in some diseases, you would never want to use the autologous cells because they're making a toxic protein. So switching gears just a little bit for the last couple minutes, gene therapy trials. So I started out with hematopoietic stem cell gene therapy and then very rapidly switched to mesenchymal stem cell gene therapy trials. So VEGF has attracted a lot of attention. These are among the most powerful modulators of vascular biology. Delivery via plasmid and purified protein injections. In these clinical trials, there was potential benefit in phase 1 and 2, but there was no significant improvement in phase 3 trials, unfortunately. So the protein delivery is really fleeting due to the very short in vivo half-life of this protein, even if you put it in with something to make it hang around for a little while. And expression from plasmids is suboptimal and transient because they really don't integrate. So there have been trials done. There's just a recap of this here, and it's nicely reviewed in this paper from 2009, so I won't go into it, but several VEGF trials. So next, what we're considering is growth factor gene-modified stem cells. You can see some of these mesenchymal stem cells here around muscles. And our current development candidate that we're working on in my group and with our vascular center, hopefully soon, is inducible VEGF secreting mesenchymal stem cells. So we have worked with transducing, putting genes into these cells for a lot of years. I've actually published a book on it. We start out with the cells that come out of the bone marrow, grow out of the bone marrow, expanded into nice monolayers. You put a gene in, you show that they're safe, you show that there's no integration sites at bad places. Very important. These are some of the papers that my lab's done since 1989, looking at these gene-modified marrow stromal cells to systemically produce cytokines, enzymes, and other factors in vivo, and showing that they are safe and that they can be incredibly effective in vivo delivery factories in many instances. So we've now tested in vivo expression of VEGF from human MSC. The MSC themselves don't have the VEGF receptor, so there are no autocrine effects, so you won't get feedback onto the cells and causing them to overgrow. They cause significant enhancement of vascular tube formation from endothelial cells in vitro, capable of sustained expression in vivo. They localize to the areas of hypoxia. They really go into a perivascular fashion. After injection, they're around the blood vessels. They're potent, safe, and effective in our preclinical in vivo studies, and we're just writing this up. In summary, the adult stem cells are paramedics. They really can migrate rapidly into regions of hypoxic tissue damage and inflammation, innately secrete factors that enhance repair and revascularization. They have the property of reducing inflammation and scarring. They're factories for trophic factors, so they can make them on their own, or we can teach them to make more. And they may remain resident in the tissue for months to years in the absence of rejection. So these adult stem cells are karyotypically stable if handled correctly, and they don't make tumors, as we've shown extensively. This is our new facility where we're currently growing up batches of these gene-modified mesenchymal stem cells. This was funded at $20 million of the $60 million total cost was funded by the California Institute for Regenerative Medicine. We have a stem cell discovery lab and then a translational lab where many of us, including our partners in the Vascular Center, share postdocs and different teams working in different bays with the goal of developing stem cell therapies, going through the toxicology testing in the humanized mice in this large vivarium, and with the goal of getting into this new good manufacturing practice facility that is a clean room facility to manufacture cells that go back into the patients. So we have 6 manufacturing labs, 3 intermediate labs. Gerhard Bauer is the director of this GMP facility. We've worked together for a long time, first in LA, then at Washington University, and then at Davis. Gerhard builds these facilities and directs them. We've done 18 cell and gene therapy trials since 1994. So what's interesting is that Stanford doesn't have one of these, UCSF doesn't have one of these, so we are getting a lot of contracts lately. And we have the mesenchymal stem cell and other cell types expansion underway for clinical trials and have banked several lots. So these are the clinical trials that we have ongoing or pending right now at UC Davis. So non-union bone fractures were started in 2008. That's a point of care trial in the operating room, moving the bone marrow into the fracture. Cardiac infarction, this is a Osiris-sponsored trial by Jeff Southard and his group, started in September 2009. Peripheral vascular disease, so John Laird and his group started in December 2010. Company sponsored. We hope to be starting another one at some point. Investigator initiated. We have one pending for retinal occlusion, which causes blindness. It's like a heart attack in the eye. We're working on gene-modified mesenchymal stem cells for Huntington's disease and Lou Gehrig's disease. Stem cell biological bandages for non-healing ulcers, liver disease, and cardiac patching with stem cell augmentation. And then finally, this is my team who run the cores in the stem cell program and work in our GMP facility, and I couldn't do any of this without them, so thank you. Sorry about my voice.
For those of us who've been practicing for a few years, we're very familiar with the term non-reconstructible arterial disease. When I was an intern, that meant that someone couldn't have an above-knee fempop bypass, at least in many institutions. It may not be that we have the answer quite yet, but we're heading in the right direction. Dr. Nolta.
Thank you so much to my wonderful colleagues at the UC Davis Vascular Center. It's just been great working with all of you since I've been back to Davis for the last 4 years. And I think we're working on some really exciting and innovative things. So tonight I get to very briefly talk about my favorite passion, stem cells. Verbal disclosure, I have no disclosures.
Atherectomy or angioplasty or stenting at multiple levels. But there's still patients who we don't have the technology to treat with revascularization. And in those cases, we're interested in medical therapies or angiogenesis or other adjuncts, including stem cell or regenerative medicine therapies. We have with us tonight Jan Nolta, who is the director of the stem cell research program at UC Davis, to talk about stem cell therapy for critical limb ischemia. First choice or last ditch. It was when I was in training that the concept of tibial artery revascularization became more widely discussed and accepted. And it wasn't until maybe the 1990s that became the standard of care at most institutions. But there were still places, including major centers such as in Houston, where if they couldn't do an above-knee fempop with a prosthetic graft, it was non-reconstructible, and that was amputation. Well, most of what we do for critical limb ischemia involves complex revascularization with bypass to distal targets or
all NIH funding and California Institute for Regenerative Medicine funding, so no companies. We have a large program at UC Davis of people working on stem cell therapies. So these are the 15 different disease teams that we have formed, 15 different areas. These are made up of 147 basic translational and clinical investigators working together. And we can only truly get to the best therapies if we do work together. So the basic scientists, we understand the stem cells, we understand